Hello there. My name is Dr. Oscar Noel, and I'm an orthopedic surgeon that works here at the Center for Spine and Orthopedics in Thornton, Colorado. Today, I'm interviewing one of our esteemed colleagues, Dr. Eric Kuhlman. Dr. Kuhlman is a podiatrist, a wound care specialist, and a foot and ankle surgeon here at our center. He has a great deal of experience performing complex foot and ankle procedures, and he completed an advanced surgical reconstructive fellowship at the Professional Education and Research Institute in 2016. That was back in Roanoke, Virginia. And while there, he performed up to 2,000 complex foot and ankle procedures during that year-long fellowship. And he has been practicing at the Center for Spine and Orthopedics for the past 4 years. I admire Dr. Kuhlman immensely. He constantly seeks to do the best for his patients and strives for better treatments and procedures that will give people a lot of benefit. And to that end, he's been involved in bunion studies over this last year. And he trained to perform a new procedure to correct bunions called the Lapiplasty 3D bunion correction. So we'll be talking about that today. Dr. Kuhlman.
How's it going?
Very good. Tell me about Lapiplasty surgery and how you became interested in offering that procedure.
So I don't know about you, Dr. Noel, but in your residency, bunion surgery just never made sense, right? Like we were addressing it and making weird bone cuts, shifting bones over and putting a bunch of screws in. And then we did midshift osteotomies and really hoped that that would work. And then we did a Lapidus, and that was, there was never like a really true logical, expert way to do this that was reproducible. And I think what I saw, at least in my practice, I don't know if you saw in your residency, but I saw a lot of reoccurrence of the deformity. So when we did these, head osteotomies, when we were moving the bone just at the tip of the bone, they would come back. And so patients would get concerned. They would get, 1 to 10 years, and some people would get lifelong, but we would have some people that just had them come back. So for me, I've always been looking for a new solution, something else out there that would make sense. And when Lapiplasty, essentially it's the Lapidus procedure, but it's guided. And when you add guides and those things in, they start to make a little bit more sense. And then on top of that, we were actually looking at the bunion in more than just a single plane. So we started to look at a rotational component. We started to look at a diverging component, a sagittal plane component. So all these different areas that go into the bunion to truly correct it. And what we saw was once we actually corrected this properly, we were able to get people up and moving even sooner than with something as simple as an Austin buniectomy. So we were doing a more complex procedure, getting people back on their foot even sooner and having just better outcomes.
That's awesome. And so you spoke to some of the benefits there of Lapiplasty surgery, but what makes this so much better than other types of distal corrections and things of that nature and soft tissue procedures per se?
Sure. I really think when we address root causes in anything in medicine, not just bunion surgery, when you truly address the root issue of the problem at hand, we're truthfully able to get that patient a better result alone, right? So with bunions, now that we're addressing the root cause and we're correcting in 3 different planes, we're actually able to get that patient up on their foot faster. We get a better correction. We have longer, results that have limited or less risk of recurrence. That's really a big benefit for me. I think just getting the patient back up on their foot's huge. I mean, once the patient's able to be mobile, I think that decreases a lot of risk for them. And on top of that, it's, a better functional surgery for the patient to be able to still do what they want to do.
That's great. So how do you do this surgery, and what can patients kind of expect?
So it's an outpatient surgery, so meaning you come in the morning and leave the same day. The surgery itself is still an open. I know a lot of people are, still doing minimally invasive surgeries, but this is still an open procedure where you make a skin incision. You essentially take that skin incision down to the joint behind the bunion. And out of that joint, you essentially start to put the cut guides on, and essentially a tool that reduces the bunion deformity itself. Once we have that, that perfect angle set and we know everything's reduced and the bunion's essentially neutral, or there's no bunion left at all, then we actually have a cut guide that goes on there. So you have to make 2 cuts in the bone to, hold that position. And then we put 2 plates on there. And these plates that we use now are so minimal compared to these big honking plates we used to use in the past that the patients aren't even noticing that. So those 2 plates then go on. We look at that under X-ray each step of the way. So, before we make the cuts, while we're making the cuts, after the cuts, once the hardware goes on, once the finished product, the hardware goes on. So we're making, a stepwise approach to make sure this thing stays absolutely perfect. and then go from there. After that, skin closure, and then you're in a dressing and out.
So you're looking at like the clinically the foot's better and on x-ray.
Yes, sir. So we're looking at it, on the table, and you're actually evaluating the position of the bunion there, as well as radiographically. So using the X-ray machine to actually see what the bone's doing, as well as our clinical judgment when we're looking at the foot directly to make sure that this looks like the best outcome for the patient.
So what other, this is kind of when somebody gets to the point where they need surgery. Is there any kind of things that you can do non-operatively, or something you can correct bunions without surgery?
So I think the problem with bunions, once they're skeletally mature, meaning once they're fully grown. So on pediatric patients, I think we have a little bit more conservative options that work. So orthotics, some splints and braces work on our pediatric patients. Once we get to adults, we do get pretty limited because we have a true deformity. So you can try things like physical therapy to strengthen up some of the muscles in the foot as well as the leg to kind of hold the position they're at now. We also try orthotics for the same purpose. The bunion's there, it's not going to really truthfully be corrected, but we can ideally stop it from progressing or try to limit its progression with some of these conservative modalities. So I've tried physical therapy, I've tried orthotics, I've tried some injections. I'm not a big fan of that. I believe that's just a tape band, it's essentially a band-aid. So we're relieving the initial pain right then and there, but essentially what are we doing to the inside of the joint, and what are we creating in the future by just injecting that steroid? And I'm not a big fan of that. So I really limit my conservative modalities to essentially physical therapy and orthotics. Now, some people try splints, some people try toe spacers, sometimes people try bunion pads. Things I don't like about that is essentially the toe spacers, they don't really stay in place really well. So sometimes people end up taping it and causing skin breakdown. The bunion splints themselves aren't really doing, unless it's all soft tissue, which usually it's not. Usually you have a true osseous or a bony pathology to it. So the splint's really not doing much besides just cranking the toe over and causing, some pain to the other side of the joint. And then the pads, I feel like they end up doing is the bunion's rubbing, right? So it's creating pressure on the shoe. The pad is just actually increasing that pressure. So even though you're putting a little barrier between it, it's still an extra layer of pressure, and the body is going to respond to that one way or another. Typically, we see pain, callousing, some discoloration of the skin with that. And so I'm not a big fan of the padding, to be honest with you.
So what do you tell patients then about certain types of shoes and shoe wear? I know that women like to wear fancy high heels and things with small toe boxes. Is that what really contributes to this problem, or is there a way that if they change their footwear, it could correct it? Or
so still with the same skeletal mature patient, the footwear is contributing to some of the worsening of the bunion deformity as well. But it's, just by changing the shoe gear, it's not going to correct it. It could limit some of the pain. And once you get a more supportive shoe, I think that is helpful. But like you say, a lot of people don't like to be in that shoe wear all the time. And some people, with work restrictions can't even wear a gym shoe or something, a supportive shoe. Good news about shoe gear now is there are a lot of options for patients. It's not just an ugly Frankenmonster type boot that you have to be in. There are certain shoes that are definitely beneficial and up to a dress shoe as well. But it's just going to help alleviate some of that pain and ideally stop it from progressing. But that deformity, once we're skeletally mature, once we're adults, has already essentially set in at that point. So changing shoe gear is a good thing to do, but I like to couple that with the orthotic as well as some of the physical therapy.
Nice. So I know you've done quite a few of these so far, and from what I can tell, your patients are doing well. What have been some of your patients' experiences with the procedure thus far?
I think most of them are pretty happy. I like to use the essentially, when you get that joint back into a proper alignment, it's like changing the tire on the rotational tires of the car. So if they're off, it's going to be painful once we get underneath it. The car's not wobbling or shaking anymore. So what we're doing there is once we get that joint into that type of good and neutral position, I think people just generally do better with the toe being in that position. So once we have everything aligned, people are like, oh my goodness, this is way better. Now you do have some of the post-surgical pain, which is normal. Swelling as well, especially in the foot and ankle. I think the swelling is more hard to combat just because you're on your foot. And so things like the pool down there. So they do get some swelling, but overall from a pain perspective, functionality perspective, they do pretty darn well.
Are you ever doing both sides at once, or if somebody needs it on both sides, are you giving them a certain amount of time between?
I really am hard pressed to do surgery on both sides at the same time. I like to give one good foot for the person to pal around on, because what you'd hate to do is, have them in two boots or two surgical shoes or something, and then they fall on one side, and then the hardware gets displaced, or the surgery gets compromised, or they are in more pain. So I don't typically like to do surgery on both sides at the same time. I like to typically do one side, give it about anywhere from 3 to 6 months, just depending on the person, before I go back in on the other side and perform the second surgery.
How long does it typically take to do the surgery?
Typically anywhere from an hour to two, just depending on kind of how the patient's anatomy is. It's a pretty quick procedure overall, I think, from a surgical standpoint, but you want to make sure you're getting the best outcome. And so you don't want to rush it. So whatever the patient's anatomy really allows me to do, and, once we get that joint back into alignment, however long that takes to make that perfect, that's what we're going to do.
Awesome. And so insurance covers this procedure, is that correct?
I do believe so. I think Medicare deems this as a true osseous deformity surgery. So once Medicare approves it, typically all the other insurance follow suit.
Is there anything else that people should know about Lapiplasty that may answer some more of their questions, or that you typically get asked?
So I wholeheartedly believe that, patients should be their own patient advocate, as well as having other people in the room to kind of hear what the physician has to say. I also believe that second, third, and fourth opinions from multiple different surgeons is wise, just because you're able to kind of get a different perspective, as well as other people's training. We all have had different training, so that sometimes dictates kind of the things that we perform. For me, with the Lapiplasty, I think the patient outcomes are just kind of shining through at this point in time. And so for me, most of my bunion practice has switched over to the Lapiplasty technique, just because of how well the patients have done and the outcomes I've been receiving. To be honest, I think that's the key for me.
That's great. Well, thank you, Dr. Kuhlman, for the very informative answers to those questions and a little bit about this bunion surgery. If you're listening into this video and want to learn more, visit our website at centerforspineandortho.com, centerforspineandortho.com, or call us at the Center for Spine and Orthopedics at 303-287-2800. You can schedule a consultation with Dr. Kuhlman to determine if you're a good candidate for Lapiplasty. Thank you for joining us this evening, or this afternoon, or this morning.
Thanks, Dr. Noel.
Have a good night.